Hello, everyone, and welcome. In this high-yield explainer, we're going to tackle a really fundamental procedure in operative obstetrics, dilatation and evacuation, or D&E. We're going to break it down into the clear, simple concepts you need to know for your exams and, of course, for your clinical practice. Okay, so let's just dive right into a common point of confusion, right? You hear all these terms, D&E, D&C, suction evacuation, and they can all start to sound the same. But knowing exactly which one to use and when, well, that's absolutely crucial. So let's clear up the confusion around D&E right now. So here's our game plan. We'll start with the core concept of D&E. Then we'll cover the absolutely essential pre-op safety protocols. After that, we'll walk through the procedure itself, talk about how to handle complications, and wrap up with the most important takeaways for your exams. All right, let's kick things off with the absolute basics. What exactly is D&E? You know, the name itself really tells you the whole story. It's a two-step process. First, dilation. We gently and carefully open up the cervix. And second, evacuation. We remove the products of conception, that's the fetal and placental tissue, from inside the uterus. It's that simple. Everything else we talk about today comes back to these two key actions. Okay, so now that we get the what, let's move on to the how. And we're going to start with the most critical part. Before you even think about the procedure, you have to think about safety. These pre-operative protocols are the absolute foundation for every single vaginal operative procedure in obstetrics. And I really want to drive this point home. What we're about to cover isn't just for D&E. This is your universal checklist. If you master this once, you've got the basis for safe practice across the board. Think of these 5 steps as your non-negotiable pre-flight check. First, anesthesia, which is tailored to the patient and the case. The patient is placed in the lithotomy position for the best possible access. Asepsis, which we'll detail in a sec, is mandatory to prevent infection. The bladder has to be empty. This just moves it out of the way to prevent injury. And finally, one last vaginal exam to confirm everything right before you start. So what does full surgical asepsis actually look like on the ground? Well, it's a whole process. It means the entire team is scrubbed in, capped, masked, and gloved. It means the operative area, the vulva, the vagina, the cervix, is meticulously cleaned with antiseptic. And finally, the whole area is draped with sterile towels. Every single one of these steps is there to prevent a postoperative infection. All right, with our safety checks complete, we can get into the procedure itself. Now, D&E isn't a one-size-fits-all kind of thing. It's generally broken down into 2 main approaches, a 1-stage or a 2-stage procedure. And this is where it gets really interesting because your clinical diagnosis is what tells you which path to take. A 1-stage D&E, where you do everything in one sitting, is typically for cases where things have already started, like an incomplete or inevitable abortion. A 2-stage D&E, on the other hand, is what you choose for an elective procedure like a first trimester MTP, or a missed abortion where the cervix is unfavorable, meaning it's firm and closed up tight. In that situation, you need a much slower, gentler approach. So how do you actually get that slow, gentle dilation in a 2-stage procedure? The key is something called an osmotic dilator. The classic example that everyone learns about is a laminaria tent. And this diagram just illustrates the mechanism so well. A dried, compressed laminaria tent is placed inside the cervical canal, and then, over a few hours, it does its magic. It naturally soaks up moisture from the cervix and slowly swells up, gently expanding and opening the cervix with very little trauma. It's a great way to prep the cervix for the 2nd stage. So once the cervix is dilated enough, either quickly in a 1-stage or after the laminaria tent in a 2-stage, we move on to the evacuation. And as you can see here, this is when instruments like a suction cannula or ovum forceps are introduced into the uterus to carefully remove the products of conception. Of course, every procedure has risks, and being prepared to manage them is just as important as knowing the steps of the operation. This is a super high-yield area for your exams, so let's really focus here for a minute. Complications can pop up right away, or sometimes way down the line. Immediately, we're worried about things like hemorrhage or direct injuries like a cervical tear or a uterine perforation. Shock is also a risk. And later on, a patient could face issues like pelvic inflammation, problems with fertility, or even cervical incompetence in a future pregnancy. Okay, let's zoom in on one of the most feared and most frequently tested complications: uterine perforation. How you react in this situation is absolutely critical. So, the absolute key point here, the golden rule, is that your management depends entirely on what caused the perforation. Look at the left side. If it was a small, blunt instrument, like a uterine sound or a tiny dilator, your first step is always to stop. Then you manage expectantly, which means you watch the patient's vitals very closely and give prophylactic antibiotics. But now, look at the right. If that perforation was caused by a large instrument, a big dilator, forceps, a suction cannula, you have to assume there could be serious internal damage. So you stop, but this case requires immediate surgical exploration, like a laparoscopy, to look for and repair any injury to the bowel or blood vessels. We have covered a lot of ground, so let's boil it all down to the 3 most critical, high-yield takeaways that you absolutely must remember from this. First, and most importantly, safety is everything. Full surgical asepsis isn't just a good idea, it is the mandatory foundation of every single one of these procedures. It protects your patient, period. Second, your clinical thinking is what drives your surgical plan. An incomplete abortion calls for a 1-stage D&E. An elective MTP with a tough cervix, that's when you reach for the gentler 2-stage approach. Let the situation guide you. And third, you have to know your emergency protocols cold. For uterine perforation, the size of the instrument tells you what to do. Small instrument, you observe. Large instrument, you operate. That distinction is absolutely vital. So that's our complete overview. At its heart, D&E is a core obstetric skill that's really defined by its 2 parts, its heavy reliance on safety protocols and a very clear understanding of potential complications. If you master these concepts, you'll be well prepared not just for your exams, but for safe clinical practice. Thanks for joining me for this explainer.